Good evening to all doctors. On behalf of Science Integra and Bharat Serums and Vaccines, I warmly welcome the esteemed faculty of the ISAR TOG LIVESTREAM webinar series, I Want to Have My Own Baby, organized by ISAR and EMOGS. Today's discussion is on recurrent pregnancy loss. We have Dr. Nandita Palshetkar and Dr. Sunil Jindal as our esteemed speakers for today. I request Dr. Sunil Jindal to share his thoughts on this topic of today's.
It's a very interesting topic because I want my own baby is the theme. Every human being ultimately wants their own babies. There is a lot of third-party reproduction today. But do we realize that in case we can give a human being, a man or a woman, their own genetic child, the fulfillment is truly awesome. And this is possible. And this is the reason we had the first episode. And now in the second episode, something which all of us see all the time, recurrent pregnancy loss. That enigma is going to be demystified. And who could be better than to speak on the part of the females than Dr. Nandita Palshetkar? And I would be speaking of something which is very much ignored, the role of sperms in recurrent pregnancy failure. So I think we would go on to the introduction of Madam Dr. Nandita Palshetkar.
Can you please share the screen? Yeah. So I'm privileged today to introduce Dr. Nandita Palshetkar, who is currently President EMOGS and Vice President ISAR. She is the professor at D.Y. Patil Medical College, Navi Mumbai, and she's currently practicing infertility for the last more than 25 years, and she's the director at 9 Bloom IVF centers across India. Dr. Nandita Palshetkar has been the recipient of several awards and has been the member of National Guidelines for Accreditation, Supervision and Regulation of ART clinics in India. Dr. Nandita has written more than 150 chapters and has received 18 awards and delivered 61 orations and more than 1,000 talks. Dr. Nandita Palshetkar has received an award as Inspiring Gynecologist of West India in the year 2019. I now request Dr. Nandita to start her talk on how to give live births to women with recurrent pregnancy loss. Over to Dr. Nandita.
Thank you, Meena. Thank you. I think it was a wonderful introduction. And, Sunil and myself had really thought that we get so many patients who come to us and they say, Doc, I don't want egg donation. Doc, I want to use my own uterus. Can you help me have a child? And this is our series of talks where we help these couples to have their own child. And today, like the first talk was on how the ovaries, poor responders and azoospermia. And now we continue with the series. Today's recurrent pregnancy loss. Give me 2 seconds while I share my screen and we are off. Yes, can you see my screen?
Yes, madam.
Yeah, I'm just going to play it. Okay. All right, so I think it's wonderful today addressing all of y'all, and we're going to be talking about recurrent pregnancy loss. According to the ACOG, spontaneous loss of 2 or more consecutive pregnancies before 20 weeks is known as recurrent spontaneous abortion. And I think I agree with the ESHRE and the ASRM that we should have two or more losses, because I know that when there is one abortion, the women are so perturbed and they come running to you, and they want to know why it has happened, for what's the reason, and to undergo a second one and then a third one before you start investigating them, it really traumatizes these girls. So I think the definition has changed to two or more, though our COG is still using three or more. This is a very old paper, but 2012, but it gives it so beautifully that what is the etiology and what are the tests. I think genetic tests, karyotype, anatomic, you can do the HSG or the office hysteroscopy, endocrine is thyroid, insulin resistance, serum prolactin level, ovarian reserve testing, anti-thyroid antibodies. Infections, we've given up TOG. There is no need to do TOG. TOG is only responsible for sporadic sporadic pregnancy losses, not recurrent. But infections resulting in chronic endometritis, cervicitis, or if the patient is immunocompromised, it can cause autoimmune disorders, anticardiolipin antibodies, lupus anticoagulant, and today we have the ANA also added to this list. Non-APS thrombophilias, homocysteine, factor V lead-in, prothrombin promoter mutation, activated protein C resistance. I think these are some of the causes which still exist and we can evaluate them. As I said before, genetic causes 2.2 to 5%, anatomic causes 10 to 15%, 20% of them are APS, and 0.5% is infections, endocrine factors, and majority of the 50% or more are idiopathic or non-APS thrombophilias. And I think those are the ones that are most difficult to treat and discuss them. Genetic factors count only for 4 to 5%, but these are treatable, and that's why it's important to identify this cause. 10% of the women who have factor responsible for the before they see, and we have treatment today, so we should definitely be able to identify it. And it should be done in family history of genetic diseases, elderly couple having difficulty in conceiving, you do POCs and aneuploid abortuses are present, and of course all recurrent failure patients. Now what happens is, if the parents are carrying any balanced or unbalanced translocations, inversions, deletions, etc., all these can be detected by a simple karyotype. Of course, microdeletions you have to ask for specially, but rest of them can be detected by simple karyotype, and that is more than enough to rule out cytogenic causes. So, karyotyping of the abortus, karyotyping of the POCs is routinely indicated now, because I feel that it really gives additional information, and it tells you whether the baby is at fault, embryo is at fault, or the mother's body is at fault. So I think karyotype of the POCs is really, really essential. But what we need to do is microarray diagnosis, the genetic study of the karyotype. But especially if you have patients with blighted ova, suspected congenital anomalies of the fetus, previous history of anomalous fetus, and she lands up with an abortion, please definitely do the karyotype and ask for a microarray. And there are laboratories which are doing it very, very reasonably now. In fact, we have a couple of laboratories and our own laboratory where we give the microarray, the NGS actually of the karyotype in just 9,000 rupees. So I think you should make an effort to find out around you who's offering the karyotype at a good cost. Now these patients can be offered pre-implantation genetic diagnosis because they have a defect which can be picked up. And how do we do it? I'm going to talk about it. Look at this. This is a day 3 embryo where a laser cut has been made. I don't know if the movie is working. No, the movie is not working. So the laser cut has been made and the pipette will go in and suck out 2 blastomeres and these will be sent. But today we have more or less shifted to blastocyst biopsy. And what we do is with the new system, that is the next gen sequencing. So if you look at genetic studies, first it was always the karyotype which was there. Then came FISH, then came microarray, and now it is NGS. NGS identifies the entire exome. So, you know, there are 22,000 genomes present and with 1 billion bases. So what this NGS does is that it picks up the faulty part and duplicates it, creates millions of copies, and then it is tested. So this is very, very simplified word of what I'm telling you. Now in NGS system, we can do PGT, that is pre-implantation genetic testing. And in that we have PGT-A, PGT-M and PGT-SR. I'm going to explain very simply to you. PGT-A is aneuploidy, that's numerical, you know, monosomies, trisomies, etc. Especially of the chromosomes 13, 16, 18, 21, X and Y. These are the 6 chromosomes for which 95% of the problems are because of the aneuploidies of these chromosomes. Then PGTM is monogenic. Now, if you know that the patient has thalassemia, you know patient has sickle cell disease, or you know that the patient has BRCA1, BRCA2, and you don't want to give it to the offspring, PGTM is done so that you identify it and you see that the child does not have it. PGT-SR is the structural rearrangements which I talked about, balanced, unbalanced chromosomes. So when you know that the parents are carrying it, you perform the PGT-SR along with PGT-A is always done in all patients. So that is it. So I'm going to skip this mosaicism. What we are doing now is NICS, non-invasive chromosomal screening. You know, I was just reading today, the ACOG has recommended that NIPT, non-invasive prenatal testing, should become compulsory in antenatal care. Why? Because of its efficiency and because of its sensitivity and specificity is more than, chorion villus sampling, etc. So NICS is here to stay now. And the same way, in an embryo, it is non-invasive chromosome screening. Means what? You have an embryo and there is cell-free DNA which exudes from this embryo, and that goes in the media. And in the media, you can take out this media and then test it for chromosomes. So it is a fantastic technique. It's completely non-invasive, no skill required at all, you know, to learn how to biopsy the embryo, which you saw in the previous picture. This is just media which is taken and used. No sample loss, high sensitivity, it's flexible, and artificial intelligence platforms are available for this NICS, which will actually tell us the implantation potential of the embryo. We have done more than 90 embryos, and 90 embryos we did NICS non-invasive and we did biopsy, and the concordance rate was 80%. So our system is validated, and we've done pregnant patients with more than 2 IVF failures, up to 7 failures, and we've had 15 pregnancies and 2 miscarriages so far. Of course, this is very early data and we are looking forward to more data. Now let's go to the other, that's the mechanical part, the uterine factors. Now uterine factors, if you have a septum, it causes, the low vascularity, so implantation is a problem. Fibroids, they release inflammatory SIRT6, BCRL6, these kind of inflammatory cytokines which cause problems in implantation. Like it increases your Th1 bias, and decreased sensitivity to steroid hormones can also be there. So septum, you resect it and you get good results, but the septum should be more than 1.5 centimeters in length at least to give you any good result. Then fibroids, if they're submucous or even intramural on the anterior or posterior wall, which are 4 or 5 centimeters, I have had the personal experience of taking them out and the second trimester abortions just drop and the patient goes on to have a very healthy baby. Endometriosis can also cause RPL, and this is all because of the Th1 bias which the endometriosis causes. It's the peritoneal fluid which has an increase, the cytokine dysregulation, there's inflammation, and that causes repeated abortions, especially in mild endometriosis. So it should be treated either surgically if it is picked up when you put in a laparoscope, or you should use GnRH analog or progesterone to suppress it in these patients who have multiple failures and with endometriosis. Male factor, we are going to hear the expert Dr. Sunil Jindal, and he does it so beautifully and simply. I think it's wonderful. So I'm going to just skip it. Poor ovarian reserve. This is also another reason why we can have multiple, recurrent abortion rate. In fact, the decreased ovarian reserve, the quantity and the quality of the oocytes decrease. And there is problems in the meiosis of the oocyte, and that is what really causes abnormal spindle and causes repeated pregnancy losses. And the DHEA supplement, when it's taken, helps these patients. Diabetes, of course, you have to control it. Remember that if your HB1AC is more than 10, then that patient has a chance of having, 30% abortion rate, and a very high chance of even congenital anomalies. So control is very, very important. Thyroid and pituitary, I think thyroid hormones and antibodies, if there's hypo or hyperthyroidism, you do have pregnancy loss, and increased thyroid antibodies, even if it's euthyroid, can sometimes cause it. The problem is you cannot treat it, there's no strong evidence, and steroids have not been recommended in these patients. Hyperprolactinemia, yes, I continue bromovercryptine or cabergoline in these patients even in the first trimester to prevent recurrent pregnancy loss. I'm using luteal phase defect. LPD is a recurrent post-ovulatory deficiency in the production of progesterone, and you especially see it in IVF patients, you see it in advanced age, low body weight, short cycles, or people who have premenstrual spotting. Then environmental chemicals and stress also can cause sporadic abortions, not recurrent abortions. Obesity, smoking, alcohol, caffeine, etc. is all sporadic losses. But exercise does not cause it, and hyperhomocysteine is responsible. Now let's come to immunological causes, and let's talk about autoimmune and alloimmune. So autoimmune, you have the antiphospholipid antibody syndrome. We know that you should have one clinical criteria and one lab criteria. So clinical criteria, what? That you can have, you have one or more confirmed episode of vascular thrombosis. Pregnancy complications, including 3 or more consecutive pregnancy losses at less than 10 weeks gestation, or 1 or more fetal death greater than 10 weeks gestation, or placental insufficiency, and high preeclampsia or severe preeclampsia. Laboratory, at least 2 times it should be repeated 12 weeks apart. You see the anticardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoproteins. These are the tests that are required. What are the treatment options? Treatment is with aspirin and LMWH. This is associated with improved outcomes for women with previous late fetal loss. And remember one thing, previously aspirin was 75 to 100, which was recommended, but the latest RCOG recommendation is that if you start 150 milligrams of aspirin, then that prevents preeclampsia in a lot of patients. So you start with 75 because there can be a lot of hematomas and bleeding, and you can increase it after 14 to 16 weeks to 150 milligrams. And heparin is wonderful. I really like this drug, and it is continued throughout pregnancy, and I'm going to talk in details about it a little later. So when to start it? As soon as the patient becomes positive. So in embryo transfer, we started as soon as we do the embryo transfer in IVF, or in IUI as soon as you do insemination. And in a patient who is conceived naturally, as soon as the UPT is positive, please start both the drugs. Dosage, as mentioned before, for aspirin. For heparin, I prefer the low molecular weight, 40 to 80 milligrams per day subcutaneously. It's very, very important to remember that. Thrombophilia also is a cause of recurrent pregnancy loss, and it can cause thrombosis on the maternal side of the placenta. It can impair placental perfusion and late fetal losses, IUGR, abruption, or even PIH. Relationship with early loss is less clear because the literature is really large and contradictory and may be restricted to specific defects but not completely defined, or the presence of multiple defects. As I told you, all those different tests of factor V, protein C, protein S, etc. Now, acquired thrombophilia is a transient condition with that increases the tendency to clot, and this might include antiphospholipid antibodies or temporary hypocoagulable states such as pregnancy. But the congenital thrombophilia refers to hereditary conditions that increase the tendency to clot. So, alloimmune or idiopathic RPL. So, for thrombophilia, again, the treatment is LMWH. That is the treatment that we use. We again start it once the patient is UPT positive and continue it throughout pregnancy. Alloimmune or idiopathic literally is 45 to 50%, because when we cannot find a cause, none of the known causes are there, then those are defined as idiopathic or alloimmune. So what is alloimmune? Close histocompatibility between partners causing improper immune response, lack of anti-paternal HLA lymphocytotoxic bodies, absence of the circulating blocking factor, like that is less PIBF, which results in maternal lymphocytes attacking the conceptors, increase in natural killer cell activity of more than 18%, and increase in T1 lymphocytes as compared to T2 lymphocytes. So actually all these can be tested now. These tests are available. Let's look at the role of progesterone. What happens is progesterone, how it acts. See, normally the fetus, there is a fetus and a trophoblast, which is 50% paternal, 50% maternal, both of them. They cause an allergenic immune reaction at the junction. And there is progesterone-induced blocking factor at the decidua, which is induced by progesterone. So progesterone level is sufficient, then there's a Th2 bias, which is asymmetric antibodies, and that causes fetal protection. But if the progesterone is not maintained, then there is symmetric antibodies, there's Th1 bias and inflammatory reaction resulting in abortion. So we must remember that the fetal interaction between the maternal and fetal cells starts as early as 2 to 3 days after fertilization. And that is why progesterone must be started early, especially in cases where there's natural conception. You must try and start progesterone at least after maybe 16 days of after the period, or 18 days after the period in a 28-day cycle. Diagnosis of alloimmune etiology, as I said, there are various tests which are available, but it's not easy to do these tests. They are not available everywhere. So what we do, and they're expensive also, so we do diagnosis by exclusion. So if you've done all the previous tests and you've got it negative, then you do it. I'm not going to talk about this. Okay. So you have a normal parental karyotype, you have a normal GTT, normal HSG or hysteroscopy, normal thyroid, prolactin, normal luteal phase, negative cardiolipin antibody, and no lupus anticoagulant, and no thrombophilia. That means then you come to alloimmune. So alloimmune is divided in, the treatment can be in two ways. As I told you, what are the causes? So immunopotentiation or immunomodulation and anti-inflammatory. So in immunopotentiation or immunomodulation, you can give progesterone, you can give IVIG, you can give intralipids, you can give steroids, you can have paternal leukocyte immunization. And anti-inflammatory, you can do aspirin, heparin, and steroids. Methylprednisolone, unexplained recurrent miscarriage, and I've used it in the dose of 8 and 16, and you continue it for up to at least 10 weeks. IVIG, I don't have experience, but you can use it and give it. It's very expensive, and hypotension, nausea, headache, anaphylaxis can happen, and you give it every 4 weeks till 24 weeks. Intralipids is something that I use. It's easily available. It's available in any ICU. It's a 20% fat emulsion. You have to just be careful that the patient is not allergic to soya bean or egg yolk. And 2 to 4 ml is taken and diluted in 250 ml saline and given over half hour. It is given every 3 to 4 weeks till the 24th week. And we've had good experience with this. Then GCSF, this is one drug which has been USD approved for RPL, and you start it immediately from UPT positive. It's to be given subcut. Each dose is given 3 to 4 weeks apart, and it's about 300 IU. Then paternal leukocyte immunotherapy is offered to overcome the immunodeficiency. Now, if you want to use this, you must do the test, because it's very important medico-legally to document the immunodeficiency and then give the reports. It is controversial, though in certain specific patients it has given good results, and usually they give it pre-conception and also during pregnancy. Progesterone therapy is wonderful. All progesterones increase the PIBF along with dihydrogesterone. They improve outcome. No demonstrable increased risk of birth defects are seen. And we have different progesterones. We have the injectable, that is IM, and the subcute. We have vaginal progesterone, and we have oral progesterone. I prefer to use the vaginal and the oral progesterone in these patients, either gels or micronized vaginal progesterone or oral dihydrogesterone. This is the slide that you must remember, that good prognosis, medium prognosis, and poor prognosis. So lesser the abortion, the patient has good prognosis. Also, if you can find the cause of genetics or early losses in normal fertility, antiphospholipid antibody positive, NK cells are normal, those are good prognosis. But when the other things happen, then what we do is empirical estrogen plus progesterone we give. PGD if karyotype is abnormal. APLA, then we use LMWH and ASA. Thrombophilia, we use LMWH. Uterine factor, we treat it. The really poor prognosis are those with 5 or more abortions, and the karyotype is absolutely normal. These are late losses, and when you perform allogenic tests and you do find NK cells are positive, then you can use lid therapy, or you can use intralipids in these patients. I would like to end by saying occurrence of 2 consecutive pregnancy losses is the definition of RPL, and thorough investigations need to be done. Structural causes, surgery is used. Endocrinological imbalances, they should be corrected. LPD, progesterone. Folic acid in DHA supplementation is a routine and specifically in patients with hyperhomocysteemia. Antiphospholipid antibody, LMWH, and low dose aspirin. Hereditary thrombophilias, it is LMWH. Alloimmune, you use progesterone, steroids, intralipids, or LIT. And if it is unexplained RPL, what I use is aspirin, LMWH, steroids, GCSF, and even intralipids. And of course, surrogacy is there, but that is something that we're trying to avoid. Now, every time I give the talk, there are lots of questions about LMWH. So I'm going to take you through a couple of slides of LMWH. So enoxaparin, dalteparin contain a lower portion of the critical pentasaccharide sequence than the parent compound. And this increases the action of 83 on factor 10A, but not on its action on thrombin. So low molecular weight heparin are not inactivated by platelet factor 4. Therefore, activity extends to factor 10A bound to the platelet membranes. And in clinical, that's why in clinical doses, no effect on platelet reactivity, PT or APTT. And that's why you don't need to monitor it totally. So it does not require routine monitoring of INR, PT or APTT. One fixed dose is administered subcutaneously, 30 milligrams. I don't use it twice a day. Generally, it's enough. 30 to 60 milligrams is what is used. Must not be administered IM and is definitely not for IV administration. Use with caution in a patient with a history of heparin-induced thrombocytopenia, and its effect is reversed by protamine 1 milligram for each milligram of LMWH. Then you have the comparison of unfractionated heparin with LMWH, and you can see the reversal agents are protamine sulfate. Routine monitoring is required for fractionated heparins. I have not used it since my college days. That's nearly 30 years ago. And because no routine monitoring is required, it's so safe. Dosing frequency, it's a continuous drip, and I think every 4 hour, 6 hourly you have to give. This is only once daily, or sometimes if the patient is obese or very high titers of ANA or APA, then we use BD. Clearance is hepatic and reticular endothelial system, no renal adjustments. This is renal. Pregnancy, both are absolutely fine. In breast feeding does not pass, and low bioavailability when it's ingested orally. So there's no problem at all. Then ability to cause what is in heparin-induced thrombocytopenia, it's well documented. Use in heparin-induced treatment, thrombocytopenia treatment, no. Use in patient with a history of heparin-induced thrombocytopenia. If more than 100 days, then you can definitely use it. And you can see the comparison of enoxaparin with dalteparin with tinzaparin, and this is just, it's for theoretical, but basically the dosages is what you need to know. That's 30 and 40 milligrams, 40 milligrams OD or 30 BD. Now this is the protocol for enoxaparin, is that which are the patients' risk factors for venous thromboembolism and pregnancy loss. Positive ANA. If it's more than 1 in 100, I definitely add LMWH. Anticardiolipin antibodies positive. History of IUGR, though the evidence is very controversial right now, but some people are using it. Prothrombin mutation, definitely yes. Lupus anticoagulant, yes. Antiphospholipid antibody syndrome, yes. Factor V lead-in mutation, yes. Unexplained infertility, we are using it. Unexplained recurrent abortions also we are using it. History of VTE, CV, DVT, yes, and history of stillbirth, sometimes you can have it. Elevated platelet aggregation score, elevated lipoprotein A, elevated homocysteine, history of miscarriages in the second trimester, history of preeclampsia, antithrombin 3 deficiency, protein C deficiency, protein S deficiency, history of preeclampsia with HELP. These are all the risk factors, and definitely we do use it in a lot of them. Starting dose is 13 milligrams subcutaneously every 12 hours. What I do is 40 milligrams OD in most of my patients. And we don't monitor anything. And the delivery, remember, look at the last line, last dose of LMWH 36 hours prior to planned delivery. For high-risk patients who have had previous history, 12 hours is okay. And for patients with lower risk, therapy may be discontinued 72 hours prior. For spontaneous delivery, delay epidural anesthesia by at least 10 to 12 hours after LMWH dose. And patients who require continued anticoagulants, I like to give it for 6 weeks. I mean, the hematologists do say that give LMWH for 1 week postpartum and then start oral. But because oral, you have to monitor the PT and APTT. Women don't give themselves, they're busy with the child, breastfeeding, etc. So I prefer the safety of LMWH for at least 6 weeks postpartum. And after delivery, you can start within 12 to 24 hours, whether it's a normal delivery or a cesarean section. Treatment guidelines for anticoagulant, even ESHRE in 2017 has said that aspirin and heparin works fabulously well in patients with APS. The RCOG guideline is in APS, it's indicated live birth rate is increased in these patients and it does not cross the placenta, so does not have any side effects on the fetus. Then evidences, this was an original article in unexplained recurrent miscarriages. And it has been shown that it increases the live birth rate in pregnancies, in unexplained recurrent pregnancy loss. And definitely this was a prospective trial. Another trial, which was a Cochrane review, which had two trials involving 242 participants, and which said that LMWH definitely increases the pregnancy rate and the live birth rate in recurrent pregnancy loss patients. So thank you very much, and I'm really happy to take questions at the end of the webinar where both of us finish talking. So I think Meenal, you can take over and introduce Dr. Sunil Jindal.
Yes, madam. Thank you so much, Dr. Nandita. So I am privileged once again to introduce to you Dr. Sunil Jindal. He is the Chief Consultant, Laparoscopic Surgeon and Andrologist and Reproductive Medicine Specialist of Jindal Hospital. Dr. Sunil Jindal is the Scientific Director of Dr. Madhu Jindal Memorial Test Tube Baby Center, Meerut, and he is the Vice Chairperson of Delhi ISAR and Delhi IAGE. He has received the Gold Medal of Best Postgraduate MAMC New Delhi and over 75 awards from different organizations. He has several special interests in fertility enhancing and gynecological laparoscopic surgery. Moreover, also special interests in medical and laboratory andrology. And he is a very good orator and a singer by passion. In fact, I would request him to say a few lines of his favorite song. If possible, that would be really wonderful. Over to Dr. Sunil Jindal for his talk on role of sperms in recurrent pregnancy loss.
Thank you very much. Thank you very much for this kind introduction. And if you ask me, two things. The most ignored person in reproduction is the man. Everybody thinks that everything, including fertility, is because of the woman. The man is not ready to give us sperm. And of course, everybody believes recurrent pregnancy loss is because of the woman. And nobody really looks at the fact that the male needs to be investigated as well. And this is the reason that we planned to go ahead and demystify sperms and its role in recurrent pregnancy loss. Just a minute, there is. Yeah. So it would make sense that recurrent pregnancy loss may have a male factor because the male contributes about 50% of the genomic content of the embryo. Now, the male contributes to recurrent pregnancy loss because of the semen factors, the sperm, the genetic factors, and of course, age has a consideration into it. Sperm integrity is very vital for the interaction between the egg and the sperm, fertilization, and early embryonic development. Now, the male has a potential to cause RPL, and normally the only evaluation done is the karyotype. And in recurrent pregnancy loss, there are two types of problems which are seen. One is a structural abnormality, and the other is a numerical abnormality. Now, the male genome contributes more to the placenta than to the female genome, And in experimental studies where they have created in animal models pregnancies with two androgynodes, they have found that the entire placenta is made by just these two. And in gynogodes is when a pregnancy is between two female gametes, the pregnancy results in an embryo with no or very little placenta. Now, What does this mean? This means that the male is very important for the decidual vascular remodeling, and this mechanism may not occur or may be abnormal in some cases and may lead to recurrent pregnancy loss. So, what are the possible causes? Chromosomal abnormality, some sperm factors, which could be in the chromosome, in the gene mutation, in the sperm quality, paternal age, and a few miscellaneous factors. So let's first go to the chromosomal abnormality. So the chromosomal abnormality can either be in the structure, and if the rearrangement of chromosomes result in creating gametes with unbalanced translocations, then it is not necessary that live births would be there and abortions can take place. And couples where one or both carry a balanced translocation are at a higher risk for miscarriage due to the fact that they may produce both balanced or unbalanced gametes. Now, we need to understand one small thing, that balanced translocations are associated with decreased pregnancy and increased miscarriages. And it is estimated that in the normal population, about 0.1% of Robertsonian translocations are there. But if tested in those people who have had recurrent pregnancy loss, you find that up to 8% of these people have a Robertsonian translocation. Well, numerical abnormalities. So as far as numerical abnormalities are concerned, miscarriages occur, living men, and more often you would see that in a few things like Down syndrome, Klinefelter syndrome, most of these men are thought to have significantly reduced sterility. So they per se are not in a condition to reproduce. But in case the embryo has these, there is a high chance that miscarriage may take place. So genetic evaluation of the products of conception, it has its importance. And what we normally do in that is a karyotype. And a karyotype includes evaluation of the number of chromosomes and any large deletions, duplications, or translocations. Now, the most common karyotype abnormality identified within the products of conception are missing or additional chromosomes. But these assays do not detect substitutions, small deletions, duplications, and point mutations. And these small disorders account for a larger number of miscarriages. We know that, well, the placenta is expressed by the male genome, and the risk of miscarriages increases above the age of 40 because of the increase in DNA fragmentation as well as aneuploidy. Now, menin binding protein, if abnormally low, has been found in couples experience RPL, and the exposure to radiation, pollution, environmental exposures, chemotherapy, radiation, cancer treatment is implicated, and how it functions is something which I'll talk in the further slides. Now let us first understand sperm. When referring to the sperm as a whole functional unit, it is not just the carrier, but it is also the carrier and the content. And the content is important because it leads to decreased or absent fertility and increased incidence of miscarriages. And whenever there is DNA damage, the chances of miscarriages increase. The evaluation of the immature nucleoprotein needs to be considered, and DNA fragmentation is a functional assessment of the sperm which is beyond the normal sperm count. So let us now understand one thing, that the testes takes about 60 to 70 days for production of one sperm. And the concentration, morphology, nucleoprotein maturation all takes place in the testicles. Now, in the spermatogonium, the nucleoprotein contains histone as the sole constituent. But as the spermatogonium matures to a sperm, it converts into protamine 1 and protamine 2. So a sperm in the end, when it is mature, has about 85% of protamine 1 or protamine 2 and 15% histone. This is a mature nucleoprotein. But what happens in an immature nucleoprotein? Whenever the histone is more than 15%, it becomes an immature nucleoprotein. And these are the sperms which are liable to DNA fragmentation, which is a very big cause of male infertility and recurrent pregnancy loss. Now, reactive oxygen species, we know, causes damage to the DNA. It leads to deletion, it leads to mutation, it leads to other lethal genetic effects. And the problem is that ROS availability is less and the standardization of this is limited. But what can we do? We can see the number of leukocytes and the leukocyte evaluation in the semen. We can see the DNA integrity testing, and this DNA integrity is of utmost importance. Now, what happens because of the oxidative stress? It affects the oocytes, it affects the spermatozoa, it affects the embryo, it affects the fertilization. And the supra-physiological ROS level leads to stress on all of them. So the oocyte, the sperm, the embryo, the fertilization, all are affected. Now, what is the biological mechanism of SDF? Number one can be protamine failure, where the replacement of histone to protamine has not taken place properly. The other can be oxidative stress, where epidermis transit, post-ejaculation, leukocytes, immature sperms, abnormal levels of plasma antioxidants lead to oxidative stress. And there can be apoptosis during sperm maturation in the testes as well as the epididymis. Now, how do you measure it? You measure it by direct tunnel assays or indirect, the SCSA and the SCD, and chromatin compaction, which are places used by probes to nuclear proteins. Now, for us to understand is that in all these tests which could be done, the simplest test which you can do is the SCD or the halo test which we hear about. But a few tests which are very well validated today are the tunnel assay and the comet assays. But number one, they are difficult to do. Number two, you really need a place which is dedicated to doing this work. So let's go on to what are the factors externally. Externally, you have pollution, smoking, drugs, male accessory gland infections, prolonged stasis of spermatozoa in epididymis or in transit, immature abnormal spermatozoa, diabetes, cancer, systemic infections. All these together lead to a problem on the spermatozoal dysfunction, which leads to infertility. Now, the environmentally, you would say that a lot of exposure takes place to phthalate, radiation, temperature. Varicocele and fever also leads to decrease in DNA fragmentation, increase in DNA fragmentation. The lifestyle as obesity and smoking is another problem. Aging, of course, all of us know, leads to increased DNA fragmentation. Now, the effects are correlated with IUI, IVF, ICSI, and the outcomes in the pregnancy. So, this is just a depiction that if an IUI is done with a normal DNA fragmentation semen, the chances of pregnancy are 19%, while the chances reduce to only 1.5% in case the DNA fragmentation is high. Now, the next is the IVF outcomes. The ICSI outcomes are much better, and the ICSI outcomes are better because of a few reasons, which I'll just tell you. Now, what are the indications of getting a DNA fragmentation? Couples with unexplained infertility, history of multiple failed IVF ICSI attempts, history of recurrent miscarriages in partner, advanced age, varicocele, poor semen parameters, arrested embryo development, exposure to harmful substances as smoking, drug abuse, occupation, and other hazards. So all these things are the indication to get a DNA fragmentation done. Now, what is the clinical value? See, DNA damage and reproductive outcome is affected because this leads to problems in fertilization, embryo development, pregnancy, miscarriages, and postnatal development. Now, one thing very important is that the oocyte repair capability is very important. So what happens in an ICSI? If the female age is less, it's a young oocyte, it has good repair capacities. So even if a sperm with DNA fragmentation is injected, its repair is possible by the oocyte. And therefore, the pregnancies in ICSI are higher than IVF in DNA fragmentation affected sperms, affected semen. Now, what can we do? We can give antioxidants and change the lifestyle. We can treat the underlying condition, and we have to avoid iatrogenic sperm DNA fragmentation. So the clinical outcome is what? That whenever antioxidants have been given, the live birth rate, the pregnancy rate, the DNA fragmentation, the live birth and the pregnancy rates are better. The DNA fragmentation goes down, and the miscarriage rates, sperm count and sperm mortality per se may not have a very significant effect, but ultimately the effect is there because the DNA fragmentation goes down. So what do we normally give? We give these patients vitamin C, vitamin E, folic acid, zinc, selenium, coenzyme Q, lycopene, carnitine, astaxanthin. There are a lot of antioxidants present. So we can give these antioxidants, but what is important is that they need to be given for at least 2 to 3 months. Now, if you find leukocytes, they are going to cause ROS, they're going to cause DNA fragmentation. So it is most important to identify whether they are immature sperms or round cells, or are these granulocytes or macrophages. So the peroxidase test is very important for us to know what exactly are they. Now the treatment is done by antibiotics, cyclooxygenase inhibitors, antihistamines, and of course antioxidants. Now subclinical male genital infections, if they are present, the most important thing for us to understand is that azithromycin given as a single dose is useful. Frequent ejaculations are needed. Antioxidants need to be added. And 42% of leukocytosperm resolution takes place. Varicocele, we all know that in case the varicocele is palpable, if the sperm count is affected, if the DNA fragmentation is affected, if there is infertility, there is every reason to do a varicocelectomy, and a microscopic varicocelectomy is the best to do. Now, gene editing on humans, the treatment, not the gene editing, that's So the treatment for this problem is lifestyle modifications. The patient should exercise, lose weight, do yoga, do exercise. Infection control needs to take place. Oral antioxidant therapy is needed. Varicocele repair is needed. ICSI may be needed and testicular sperm may be needed in case the sperm DNA is very high. So what happens is the sperm in the epididymis has a higher DNA fragmentation, or in the ejaculate for that matter has a higher DNA fragmentation, and a testicular sperm has lesser because it is exposed less to ROS. Therefore, these things can be followed in patients who are infertile or in patients who have recurrent pregnancy losses. Now, the reason for success in ICSI, I have spoken about the oocyte repair. It is important that the younger the woman, the better it is, and the lesser the prolonged culture. See, IVF has a long time for culture compared to ICSI, and the longer the culture, the more the damage. And the stress, the sperm DNA is caused by oxidative stress. In ICSI, the oocyte is protected from this attack and can use its energies to repair the damage in sperm immediately following fertilization. Now, how do you avoid short abstinence? You instruct the patient to deliver the specimen 1 to 2 hours before. You process specimens as soon as possible. Keep specimens at room temperature using appropriate culture media. Incubation time should not exceed more than 4 hours. And thaw cryopreserved samples just before the procedure. Now the take-home messages. Number 1, sperm DNA fragmentation provides information that is different and is of a better prognostic value. Sperm DNA fragmentation occurs during the transit through the epididymis and is mediated by ROS, and the oocyte can repair the ssDNA but not the double-stranded DNA damage. The test is sperm chromatin dispersion test, which is the simplest to do, and in vivo as well as in vitro, sperm DNA fragmentation has an effect on fertility as well as on recurrent pregnancy loss. So we need to have these strategies which I've talked about, and we have to avoid iatrogenic, which I've talked about, and there is a lot of value of this in prognostic and diagnostic value, and the function future is well understood. Now RPL is multifactorial, and we're just beginning to scratch the understanding of the male contribution. Epigenetic biomarkers will be there in the future. Genetic, epigenetic and environmental factors, growing need for more reliable tests is needed. And testing of sperm chromosomal abnormalities and DNA fragmentation appears to be a reasonable option for the male partner. Further understanding to this complicated ailment will allow us to be better educated. And till now, about 40% of RPL cases remain unexplained. The female factor plays a major role, but the male also has a role. So at this, I'll end over here, and thank you for being such a wonderful audience, and thank you for being here. Hello? Yeah. So, Dr. Palshetkar?
Yes, Dr. Dr. Palshetkar has got disconnected. I'm trying to connect her.
I beg your pardon, I can't hear.
I'm here.
Yeah.
Okay. So the questions are there, and I'll just check out the questions. Now, there is one question which is from Dr. Sushma Survey. Genetic testing by array CGH is recommended by ISRE. So I want to know whether I can do it for less than 6 weeks abortion, second abortion, or only karyotyping is enough for less than 6 weeks to confirm unbalanced translocations.
For unbalanced translocation, you can just do a simple karyotype also. That will also tell you. But if you're doing microarray, that will give you a lot more information. So it's good enough. And you can do it for any age.
Great.
Is that okay?
I'll just add to it that
Yeah.
the ISRE recommends that if there are more than 3 abortions, then you go ahead with this. And the ASRM says that even with 2 abortions, you could go ahead with this. And of course, what Madam has said is the addition and the main point.
For one.
Yeah. Now the second question is
Yeah.
vitamin D3 related to RPL in female partners?
In a few cases, it has been shown that vitamin D is responsible because it's required in everything. But the jury is still not out. Some people do say so. I always correct vitamin D in patients who are RPL.
Correct. Now there is this question which is there is how to counsel a couple with unexplained recurrent pregnancy loss. And ma'am, if you give me the permission, I'd like to answer this question. And
Yeah, please go ahead.
so normally the man and the woman both need to be counseled together, and the woman needs to be given a lot of tender loving care, and the man needs to be told at that moment that there may be a role which you have too, because it decreases the pressure on the lady because of this. And another important thing is that whenever you do this, you have to tell them that we are investigating you. We may be able to find something. And in case we do not find anything which is suggestive, even after that, there is a very good chance you could have a pregnancy and we could go ahead with it. Madam, could you add to it, please? Dr. Palshetkar.
I need to unmute. Okay. In unexplained infertility, I think the most important thing is that you do all the tests and sorry.
Then I'm not able to look at.
Hello, can you hear me now? Yeah. So you need to check out that all the reports are absolutely normal. Okay. And do the karyotype, do the my first slide, which says do all the tests, and then you explain to them and give empirical therapy. I think that's very, very important. And if the person can afford it, then it's worth doing the lit therapy. But I would generally not do it unless there's 3-4 abortions.
In acquired thrombophilias, what are the tests that you do? ACA, lupus anticoagulant, and B2 glycoprotein, is it enough?
In acquired thrombophilia, I think the protein S, protein C are also good to do, and homocysteine is important. So, and along with these tests, I think these also should be done.
Now, there's another question which is, do you routinely check homocysteine levels? Please explain. Well, homocysteine is
Yes.
a higher homocysteine means less of B12, and this has been used by some people, but we as a routine do not do it. I do not do it as a routine, but
No, neither do I do it as a routine. I just give the
treatments, correct,
empirically.
So now this is, will non-centrifugation method of semen, what is this? What in your opinion about method of semen preparation? Well, if you want to do a semen preparation and you want to have the least number of DNA fragmentation, three basic things. Number one, get a sample immediately, process it immediately. You can process it by sperm wash as well as DNA fragmentation. If the sperm count is less and if you find that the leukocytes are high, you would go ahead and do a density gradient. Fragmentation takes place in both. It depends on the sperm quality, what you would like to use. Next is, will non-centrifugation method for sperm DNA fragmentation decrease DFI? Well, if you do not centrifuge, the chances that the ROS would be there would be less, but the harvesting is very low. So once the harvesting is low, it depends on what you need it for. So this is where it would be. And the third is, Madam, there's a question for you, and this is the role of anti-nuclear antibodies.
Of anti-nuclear antibodies. Anti-nuclear antibodies, if the dilution is more than 1 in 100, then they become significant and you must add LMWH to these patients.
So, ma'am, we are at the end of the program on RPL. And just a minute, there is one question. Now people are asking questions. So there's a question which has just reached me. And this is, what do you do if repeated loss of cardiac activity around 10 weeks in spite of low molecular weight heparin, ecosprin and progesterone?
Hello. That's a real tough question. If there is repeated loss at 10 weeks, I would give this, plus I would add intralipids and GCSF to this. That's all that I can add to it. Estrogen, progesterone, steroids, I would give the whole gamut along with the ASA and heparin. There's nothing else you can actually do over here.
Now, there is a question. What is the role of Bharglobe, immunoglobulin, in such patients? Till what time should we give it?
We have more than 80 now.
So I think I don't use immunoglobulins, but immunoglobulins have a role in these patients, especially if they're alloimmune, and it causes immunomodulation of these patients, and it should be used every 4 weeks, 3 to 4 weeks, up to 24 weeks.
And there's another question which has come here, and this is, if a patient comes at 31 years age and history of not conceiving, should that patient be investigated for causes of RPL? Because if she has such a problem, treatment and investigation for infertility will just increase maternal age.
I would normally do, the APA antibodies, because that is something that be treatable at the moment. I don't bother with factor V lead-in and all because they're more rare. But anti-phospholipid antibody syndrome, I would do in certain patients. But I would do one IVF. If it fails, then I would go for that, not just straight away. Yeah.
I would think so too.
Yeah.
So, madam, we are at the end of this session. And you were at some lovely exotic place which we can make out. And it's great that despite of the net being poor and despite of the fact that you are there for a holiday, that you are here with us, and the net has been kind enough to have everything. Now, there's Dr. Sutha Jyoti V from Chennai. She is brilliant. She's asked so many questions. She has one question which has come into the chat box, ma'am, and I'll just to Dr. Nandita.
What is the question?
What alloimmune test do you do practically?
Nothing. I just give empirical therapy. But if there are 5 abortions or something, then I do refer them for lead therapy. So then all those, the lymphocytotoxic antibody, paternal antibodies, all those things are done.
And there's another question she's asked, which would be the last question, ma'am. And this is the experience of hydroxychloroquine in RPL.
I don't use it, but yes, in patients with repeated pregnancy loss and APS syndrome, it's been used by some people with SLE, etc. But I have not used it. In my SLE patients, actually, it was given to the patient already, but they become worse. So they are. I don't use it specifically, but if the patient of SLE is on its CQ, then I continue it.
So now we have answered most of the, in fact, all the questions which were there. And it's been such a pleasure to be here and such a pleasure to be a part of this whole webinar series. And thank you, Dr. Nandita, for being with us on a holiday. And it's been really nice and really kind of you. So it's a fantastic program we've had, and we look forward to you being there with us in the future programs which will be there.